Hello, I'm Caroline McGraw from The Clearing. Today we are thrilled to be speaking with author and activist Dr. Sally Satel. She is a practicing psychiatrist and lecturer at the Yale University School of Medicine. She examines mental health policy and political trends in medicine. She's the author of several books, and in this interview we'll be talking about her latest book, Brainwashed: The Seductive Appeal of Mindless Neuroscience, which she co-authored with Scott O. Lilienfeld. Have a copy right here. Specifically, we're going to focus in on Chapter 3, Addiction and the Brain Disease Fallacy. So thank you for joining us, Dr. Satel.
Oh, thank you for asking me, but I just want to clarify something right at the beginning. It's funny you called me an activist. People rarely do, but they have, and I say I'm not an activist, I'm a reactivist.
Ooh, I
and
like
what
that.
I mean by that, because actually, I know you, of course, meant totally well, but I think of an activist as someone who actually doesn't look at the data, but is really driven by ideology. And in our book, Scott and I certainly wanted to do that. But I'm a reactivist because I think that, well, in fact, the brain disease model, which is, I know, something we want to talk about, that's something I react to. And I, in general, think it's not been the most constructive development in this field.
Well, thank you. That's a great clarification and a really good jumping off point for the first question, because in your book, you do a great job arguing for revisions for the current model of addiction. So before we dive into that, though, could you just fill our listeners in, if they're not familiar, what is the prevailing model? What is the brain disease model?
Well, the formulation, addiction is a brain disease, was actually first introduced, and I was there at the beginning in 1995. I distinctly remember the then director of NIDA, the National Institute on Drug Abuse, whose name was Alan Leshner. He was a psychologist, and he introduced it at a meeting that was sponsored by the National Institute on Health. And I thought, well, that's a very strange way to think about it. I mean, certainly drugs affect the brain. Why would people take them otherwise? And there's no question that they cause changes in the brain, which if you ask Dr. Leshner, what do you mean by it's a brain disease? That's what he would say, because drugs change the brain. Of course, as an aside, when you think about that, it's not very satisfying because everything changes the brain. I mean,
True.
This conversation will change our brains and people listening to it. Now, granted, there are brain changes and then there are not all brain changes are the same, and we'll get back to that in a minute. But anyway, so he said it was a brain disease, and I know that, of course, addiction and alcoholism have been considered diseases for probably ever since Benjamin Rush, or at least he introduced that in the late, over 2 centuries ago. But even then, it had a kind of a metaphoric quality. I mean, certainly it's a form of behavioral pathology. I mean, how could it be healthy to constantly sabotage yourself and injure your body and risk overdose? That's not a healthy way to live. And in psychiatry, we would certainly consider it a disorder of behavior. So the disease part didn't bother me so much. It only bothers me, and today it still does, when people invoke it as a reason why they do what they do. In other words, they have no control and they can't do otherwise. And that is not the most constructive use of disease in this context. But if that's a reason a person, finally got through to someone, this is why I really need help, and this is why I have to do these things, then I'm totally fine with it. I would never debate a patient, someone who was working towards getting better, how they think about their problem if it was ended up being constructive for them. But the brain disease thing took it into a whole nother realm, and it made it essentially interchangeable with schizophrenia, Alzheimer's disease, multiple sclerosis. And there's a big difference between the brain changes of, let's say, Alzheimer's disease and addiction. Yeah. I think it should be obvious, but let me just illustrate.
Sure.
And I'll illustrate with a case of our former drug czar, Michael Botticelli, who's a lovely man. I met him. Everyone loves him, and I can see why. But sometimes I've heard him say things that seem to contradict. So he was a big champion of the brain disease model. But it turned out, and he's been very public about this, he was an alcoholic at one time. I think he's been clean in recovery for over 20 years. And he was driving erratically on the Mass Turnpike,
Mm-hmm.
and I think he got in an accident, although thank God no one was hurt or killed. But he got arrested for drunk driving, and the judge told him, well, you can do two things.
Mm-hmm.
You can go to jail, because that's what we often do with people who drive drunk. But I imagine he had a good record previously, so the judge was really quite generous and gave him the option of getting clean, basically.
Mm-hmm.
Go to a
Mm-hmm.
treatment program. You do what you have to do, just you're going to have to get clean, and we're going to make sure of that. And so Mr. Botticelli, with his brain disease, said, well, wow, this is, thank you for giving me this choice, and I choose treatment. And he actually, I believe, went to AA.
Mm-hmm.
The way he phrased it, he said he went to a church basement and then went to AA, and, and has done well since. So if you take the brain disease notion to its extreme and analogizing it to Alzheimer's disease, which its proponents sometimes do,
Mm-hmm.
then no matter what kind of options a person gives you, for example, if your memory deteriorates any further, you're going to have to go to jail.
Right, right.
Or if it does, if you can keep it from deteriorating, we'll give you $1 million. It doesn't work that way, because the changes in the brain that accompany addiction do not prevent the person from responding to meaningful consequences, and be they incentives or sanctions. And that's a key difference.
I really like that. Yes, you have a great line in the book that you talk about. Addiction involves both biological alterations to the brain and deficits in personal agency. So it's not either or, it's both
No.
and.
And actually, though, of course, Carolyn, unless you're a Cartesian dualist, I mean, everything is in the brain, of course. I mean, we wouldn't be having this conversation if our brains weren't working. But at that point, it becomes trivially true. Of course, it's all about the brain. So some people will say that. I've actually heard some people say it. Well, even when you're in treatment and you're doing relapse prevention therapy, it's in the brain. I said, well, of course, it's in the brain. Everything's in the brain. That at that level, it doesn't really mean much anymore. But when you're going to talk about brain disease as a reason why a person frankly should not be held accountable, and I don't mean punishment in any kind of a lock 'em up sense. That's not what we're talking about. We're talking about shaping behavior in the direction of recovery and being functional and reuniting with your family and your community and feeling purposeful in life and content and all that. Sure, your brain's going to play a role in all that too. But again, a highly mechanistic explanation of addiction doesn't lead you to think that way. It doesn't lead you to even ask questions like, well, why did you become an addict? That's a meaningful question. Why did a person become an addict? Would you ever say to someone, why did you become an Alzheimer's patient? I mean, of course, they might. Someday, we will probably be able to explain the pathophysiology of it. And I hope they do it quick, because that's a devastating illness. And that is the neural level, or what Scott and I would call the neurocentric approach to Alzheimer's, is exactly where we want to be, because that's the tissue damage, the circuitry deterioration, and so on in Alzheimer's is only going to be fixed by working on the brain. But in addiction, not that much is fixed by directly intervening at the level of the brain. And even the medications we have, when you think about it, and I'm all for them, I work in a methadone clinic, there's nothing I've ruled out. If anyone wants to go to AA, great, if that works for them.
Yeah.
If they want to take methadone, fantastic. They want to stop on their own, which a lot of people actually do, but we don't hear about them very often because, they stopped on their own. They're not people who come into research programs. They're not people who come into treatment centers, so they don't get counted, but they can stop on their own. I think I lost my train of thought there a little bit, but
That's okay. I love in the introduction to chapter 3, you talk about these studies that many people forget of the US soldiers who went to Vietnam and they were using, and then they came home and they stopped. And that this is a narrative we don't hear as much. This idea that under the right conditions, recovery is not just possible, but it's even probable that people will recover.
Yeah, and you used a key phrase, which is under the right conditions.
Yes.
And look, a lot of people are under terrible conditions. All their friends use, their communities, especially we, hearing so much now of the opioid crisis, these economically ravaged places. There's no hope. There are no jobs. It's all, I mean, painkillers and heroin is highly accessible. It's virtually normalized. Everyone else is using it. I mean, it takes a lot for someone in those circumstances to pull out of it. I understand that, but part of the goal of treatment is to change the circumstances, and until there's an economic recovery in these places, unfortunately, that kind of solution, and I like to look to the environment, but that kind of solution is not around the corner. But there probably are more creative things that can be done at the local level, than we imagine. And hopefully they're going on right now in places, in Kentucky and Ohio and Maine and all this. But it is an incredibly big challenge because in a way you're talking about addicted communities. And that is hard. But when we talk about addicted individuals, let's say, the person who appears to have everything, or just go to Hollywood and you'll find, very talented, very smart, very wealthy people who still, struggle with drugs and alcohol. And maybe this is where I'm catching back up with where I lost my train of thought before, but it does make sense to ask why, why are you having these problems? And you'll usually get a psychological answer of sorts. And everything from depression. Sometimes it's clinical depression. Sometimes it's clinical anxiety. In which case, me as a psychiatrist, kind of think, "Oh, great!" because we actually have medication for that.
We can help you.
Yeah. Sometimes it's a little more existential. These pervasive feelings of loneliness and aimlessness and desolation and never feeling comfortable in your skin and that's harder to work with, but you definitely can.
Yes, that is predominantly the participants that come through our program are dealing with dual diagnosis. They're dealing with often a diagnosed mental health concern and the substance abuse. And so I don't know, I loved this line in your book. The paradox at the heart of addiction is this: how can the capacity for choice coexist with self-destructiveness? And that's what we see so much in our program. You have these smart, capable, amazing, or like you were talking about, individuals who seem to have it all, and you're thinking, why are you self-destructing?
Right.
And that's the time where you, or I should say we, really try and delve into those underlying core issues and address those psychological concerns that you were talking about.
Right, right. And when you quoted that, it reminded me, it may even be in the same paragraph, I'm not sure, of one of the sort of stock phrases of Dr. Nora Volkow, who is now she's the head of NIDA and has been a very, very vocal promoter of the brain disease concept. And she's fundamentally a neuroscientist as opposed to a clinician. I think that's fair to say. And so what she likes to say is, I've never met anyone who wanted to be an addict. Well, I don't know. I haven't either. And I've never met anyone who wanted to be overweight or poor. I mean, these are circumstances that come about incrementally, and they're not the goal that people are seeking. That no one wants to be fat. No one wants to gamble away their life savings. But, what they want is immediate relief. And that relief, they get it in the short term. And then, of course, there's fallout. And then you've got two layers of problem. One, that layer that kind of generated the motivation to use, and then all the fallout of your using for years. So you've alienated your family and your boss, and you didn't finish your education, and so then there's even that compounds your distress, and you could see more reason to continue to use. So it's a terribly vicious cycle.
Exactly. I love how you said that. There's layer on top of layer. There's what you started out with, then there's the dysfunctional behavior, the shame, all this stuff surrounding the addiction that was to try and cope with the dysfunctional issue or psychological trauma or whatever else you have.
Yeah. But, you know, shame is an interesting thing. And I actually think, you know, when I have patients say that to me that they were ashamed, I think that's healthy.
Mm.
I say, well, thank God, you know,
Yeah.
kind of your sense of right and wrong is still working.
Mm.
It doesn't mean that anyone should go out of their, any clinician should ever make a person feel worse or scold them in any way or make them feel ashamed. People feel bad enough.
Yeah.
But the fact that they do is not something I try to say, oh, don't feel bad. No, I said, well, that's healthy.
Yeah.
And so what are we going to do to get the trust back, of your family and your kids and this kind of thing? But you're also right that when it can be a spur to continue to use, and that's where it's not constructive.
That's really helpful, though. I like that almost people feeling ashamed that they have so much shame,
Yeah.
but you're kind of reframing it as like, no, this is a sign that you have some health here and some discernment almost.
Yes, I think so. And I never had anyone say to, look at me and say, what? They say, oh,
Yeah.
anyway, that's how I kind of know whether or not you don't want to offend anyone, but I don't believe I've offended anyone yet by saying that. And they seem to, think that's a valid point.
It is, because something that kind of boggles the minds of our participants, and I had gone through the program as a participant myself, is this whole idea that what we have inside of us, our emotions and everything, are trying to teach us and they're trying to show us something. And so I like this idea that the shame is trying to bring you to your own attention.
Yes, that's a good way to put it. That's a nice way to put it.
Yeah. Thank you. Well, going back to, you mentioned loved ones, family members, kind of the ripple effect of addiction.
Yeah.
And I liked how in your book you talked about the importance of natural consequences and how often loved ones will try and shield people from the natural consequences of their using. So I know there are a lot of loved ones and family members listening. So could you offer more on that? Any suggestions? Any guidance there?
What I remember writing is that it's the loved ones that often pressure them into coming in.
Yes.
I don't know how, I haven't seen the literature on intervention, so I don't know about those, but just the subtle, well, they go from subtle to, your wife gives you a look when you've missed your kid's ball game,
Mm-hmm.
to your wife leaves you.
Mm-hmm.
But that's what, most people come in because something's falling apart. And more often than not, it's someone else who's really calling their attention to it. I think that these consequences are the fact that people see other people becoming disappointed in them is very motivating. Now, it's true that, there are all these various ramps at which people get off. Some people just get off, meaning the ramp of drug use to recovery because their wife gave them a dirty look, or their kid, said, Dad, you missed my game again. And it's devastating to people. And other people, go a long way down before they get off. And I mean, there are always some people who just never do. But, and there's a bit of mystery to that. Some of it is also that the conditions, as you say, aren't quite right yet. And also, I think sometimes it shows also how difficult. I think this is why people are so ambivalent about giving up their drugs, is because they're not ready to face life without some numbing,
Yes.
And as we alluded to before, the further down you are in that spiral, the more numbing you almost feel you need. So it, again, a vicious cycle.
That makes so much sense. So much sense. And I also liked how at the end of chapter 3, you redefine addiction outside of the brain disease model. And I was wondering if you could share that revised definition that you have come to through your research.
Carolyn, actually, can you read it to me?
Absolutely. Yeah, I have it bookmarked.
Mm-hmm.
And, okay. In the end, the most useful definition of addiction is a descriptive one, such as this: addiction is a behavior marked by repeated use despite destructive consequences and by difficulty quitting notwithstanding of the user's resolution to do so.
Oh, I see. Okay. Yeah, I suppose if someone held a gun to my head and said, well, if it's not a brain disease, what kind of a
What is
disease
it?
is it? Then
Right.
I suppose if this were my choice, that, pick one or die, I'd say it's a behavioral condition because unless somebody acts a certain way, you'd never call them an addict. But, Scott and I really tried to get away from it's a brain disease, it's not a brain disease, and to focus more on what we call levels of analysis or explanatory frameworks. And our thing is that it's just not that constructive to call it a brain disease because you're focusing too much on the level that is just a small part of the whole process. In fact, I think calling addiction a brain disease is a great disservice to an extremely complicated set of behaviors. To me, it's fundamentally a human drama, but so we like to talk about, well, you can that's a neurocentric view, that the looking at the brain is the most powerful way to explain it. Well, if you're a neuroscientist, if you're a dopamine biologist, it probably is. But if you're a person who wants to get better, a family member who wants you to get better, a treatment provider who's there to help you get better, a policymaker who wants to make the best policy, that's not the level. It's more at the level of behavioral and psychological and even environmental factors. So it's really a matter of emphasis. And that's the point we really wanted to make. Even when you look at medications, they're actually not, okay, maybe I sound like I'm splitting hairs here, but I don't even think they're treating addiction so much. Take methadone. That treats withdrawal. And to some extent, it suppresses craving. So it's highly stabilizing for people. And there are some people, I think the minority, but there are some people who continue to use opioids largely because they cannot tolerate the withdrawal. So for people like them, these replacement medications should be the greatest thing in the world.
Yes.
And for some, they probably are. But then you'd ask, well, why are so many people in our methadone clinic still using heroin, granted at a much lower level than they were before? Why are they using cocaine? Why are they drinking? Why are they, because it wasn't just about the withdrawal, because there are other things driving their drug use. And then buprenorphine, same basic thing. And then there's Vivitrol, which is an injectable naltrexone, which is a blocker. And so I support everything, let 1,000 organs bloom. Let 1,000 flowers bloom. But anyway, but even some of the brain disease proponents like to talk about the medications that they've helped generate. Well, all these medications existed before we had the first brain scanner, which isn't to say that, maybe one day there will be more effective medications developed. I'm personally kind of skeptical that medication will ever be a major answer to this problem. But I think it can help a lot for certain people. I like to tell young people that if they get on methadone or buprenorphine, don't look at it like it's their life's duty to stay on it. In our clinic, which is in inner city Washington, D.C., the average age is 57. So, these are hardcore, old school addicts. They started with heroin. Nowadays, most people start with pills. They've been in and out of programs forever. And a number of them have decided, and I think wisely, it's like, hey, for some reason, I can't get off this, or every time I do, bad things happen. So they just stay on it, and they'll probably stay on it forever. And that's fine, because that's the responsible, thing to do. But if you're a young person, you should really look at those medications as a temporary kind of aid.
That makes total sense. Yes, it's like this can be a bridge to where you want to go, but it's not the end destination.
Right.
Yeah. And you also talk about in your book this idea that one of the sort of current advantages to the brain disease model has been getting additional funding for addiction research because it's been framed this way. But of course, one of the major drawbacks is that it downplays personal agency and it's not a complete picture. So, could you say more about that?
Well, I do acknowledge that there are good sentiments behind the brain disease, right, to get more research funding. Because in 1995, um, Harold Varmus was the head of NIH, and it's well, independent of Harold Varmus, who's a brilliant oncology researcher. I believe he has a Nobel Prize. NIH is a biomedical institution, so I can see why there was such an effort to make addiction seem like a neurological problem. And again, it has those elements. There's no question about it. But right, the idea was to get more funding within NIH and to, I think, secondarily get more treatment funding. And some people emphasize the highly reductive model of addiction to kind of move cultural responses away from punishment to
Yes.
a treatment. And all that's great. Whether it did any of those things, I honestly don't know. I mean, we had a huge crack problem around that. I mean, you could come up with a million other reasons why there was more research funding, and there was. So it's hard to know. But if it helped, then I'd say that was a positive outcome. But I think it's based on a deep conceptual confusion, and I always think it's better to be clear thinking and even if there are no implications. But in this case, the implications to me are tremendous because unless you have a realistic view of the nature of addiction, you're not going to come up with good policies and treatment programs.
Exactly. Exactly. Could not have said that better. And I want to honor your time, and I'm so glad you were able to be with us. So, just to wrap up, is there any final points you want to share or encouragement for folks who are dealing with addiction? Any closing words?
Don't get too, I suppose my suggestion is just don't get too caught up in slogans and models and this and that. Just know that, people have come before you. A lot of people have stopped. Most people actually have stopped. And many of them have actually stopped on their own. Obviously, you're in a program now, so that didn't work out, but it should be encouraging to anyone that this is certainly possible, and have things in your life, work to things in your life that you don't want to lose, because once you have them, you probably won't risk them. And that's and one of the very important ways to stay clean and move on. So I wish you the best.
Thank you so much.